message and you'll know we're getting ready to go live. All right, folks, if you're on our YouTube channel, thanks for joining us. You're in the proverbial green room with our guests. We're getting ready for an incredible conversation we've planned on transforming Part D changes into opportunities for member value. Bear with us as we get ready to get started in front of our live Zoom audience. Okay, here we go. We're going to get started. Is everyone good to go? Thumbs up. Good, good, good. Awesome. Deanna, we still have you off camera, so you'll be ready to go. There you go. Awesome. Here we go. Thanks so much for doing this again, everyone. Welcome back, everyone. This is Eric Glazer at Bright Spots in Healthcare. This show is produced by Bright Spots Ventures. Each episode, we bring leaders together to not only inform you, but also unearth bright spots, successes at health plans, hospitals, and other healthcare organizations across the land. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. If you want access to a library of your peers, all kinds of leaders at health plans and other healthcare organizations who are offering up their bright spots, I strongly encourage you to subscribe to the Bright Spots in Healthcare podcast. You could find Bright Spots in Healthcare anywhere you consume podcasts, or you could subscribe via our YouTube channel if you want to see the video version of this show. I encourage you to do it not because you get to hear my voice, that's the least. It's because we get so many great guests who are so smart and offer so many great ideas from their organizations that I believe could help you make healthcare better for all of us. So that's why I encourage you to listen to the show, tell your colleagues and peers about it. Would really appreciate it. And by the way, if you like it, please put a comment in and maybe even give us a 5-star rating. That helps more of your peers organically find the show. So appreciate that in advance. All right, let's get it started here, because we know from star ratings adjustments and all the stricter oversight that we're now in reporting requirements with the new administration, we have a clear message that translating policy into action isn't just about compliance, right? It's about creating a competitive advantage for your organization. And for plans serving duals, managing medications, and tackling social risk factors, the stakes are going to be super high. So how are leading organizations rising to that challenge, and how are they turning regulatory pressures into measurable results for members, for outcomes, and for their overall operations? That's what we are going to unpack over the next 57 minutes or so. I want to first thank today's partner, MedWatchers. We do not do this show each and every week, and we've been doing this show for now almost 12 years, without the incredible support of some of the solution innovators around this industry. MedWatchers is our latest partner in crime, and they are a true leader in healthcare technology and clinical services. They support over 60 health plans, including the six national ones, and play a critical role in partnering with health plans to improve their Medicare star performance through targeted clinical programs like med adherence, medication therapy management, and polypharmacy. And I'm going to tell you a lot more about them later on during the episode. But if you want to get a little bit of a preview and insight into who they are and what they're all about, you could check them out at medwatchers.com right now. All right, let's get into it. Let's find those bright spots. Our topic today, transforming Part D changes into opportunities for member value. We have a superstar panel planned in front of you as usual. And at the same time, we're going to bypass their introductions. We only have about 55 minutes left, but we will post their bios both in the show description on your podcast app, and if you're watching live on Zoom, we'll put it into the chat. We'll post their bios there. We have for you Melissa Skelton Duke. She's the Executive Director of Medicare Quality and Star Strategy at Banner Health in Arizona. We have Deanna Homer. She's the Chief Operations Officer at HealthTeam Advantage in North Carolina. Both those plans have 4+ star MA products. And last, and certainly not least, we have Bita Farrokhroo. She is the founder and CEO, entrepreneur extraordinaire at MedWatchers, and has a lot of interesting stories to share about health plans around the country. Again, check them all out through the bios that you see in your chat and in the show notes. We're going to have a great conversation. It couldn't come at a more critical time. CMS finalized its 2025 Medicare Advantage and Part D rules, reminding us that the regulatory bar is getting higher, especially when it comes to member experience, care coordination, SDOH. So let's start with you, Melissa. Recent changes to Part D present challenges and opportunities, right? So how are you guys at Banner Health leveraging these changes to enhance the member value, particularly for those with social risk factors in this shifting regulatory environment?
Yeah, great question. And first of all, I wanted to just start out by recognizing that plans who are able to achieve 4 stars, my hat is off to all of them. It is not an easy feat. And I will also just disclose and clarify, we are on a journey to 4 stars as a plan. We are currently sitting at 3.5 stars in my plan. But we are working really hard towards that milestone. And I can share really happy and proud that on the Part D side, our plans have achieved that 4-star rating for those Part D metrics. So just to clarify that. But back to your question, I think it is a good question, and it's one that all of our plans grapple with. And it starts with really understanding sort of what are the behaviors of our members and looking at mapping those behaviors to what our sort of traditional assumptions and notions are around what drives medication adherence. And so for those of us with responsibility for Part D stars, medication adherence is what we wake up thinking about and go to bed at night thinking about. And so when we start to do that mapping and we start to think about things like, okay, well, we know that maybe members that are on mail order have a tendency to look more adherent than members who are using a community pharmacy. We know members that are filling their med adherence drugs in 90-day supplies are more adherent than members who are filling their med adherence drugs in 30-day supplies or less than 90-day supplies. And so as you start looking at some of those trends, you can start to say, okay, well, let's get everybody on mail order. Let's get everybody in those 90-day supplies. But when that doesn't always work, it causes us to have to kind of go back and look a little bit deeper. And so one of the things that we did in our plan, understanding our population and kind of what drives them, we knew that we weren't getting the mail order uptake that we thought we wanted, right? In the population, we had promoted it, and you ask members, we can help get you signed up for mail order. Let's make this really easy for you. But we weren't really seeing the uptake. And when we started digging deeper and really asking deep questions of our members about what makes them choose the pharmacy that they choose, we recognize that it's a number of things. One, it's the relationship that they have in their community. It's the relationship they have locally with their pharmacist and pharmacy technician team. Those are people that they're neighbors and they're friends and they've known each other for years. And so we want to be respectful of those relationships. We also know, as we started looking at those behaviors, that in particularly our dual population, we have a transportation benefit, and someone can use their transportation benefit to go to the pharmacy and pick up their medications. And if their pharmacy so happens to be at a grocery store or a big box like a Walmart or something like that, they can do a lot of other things for themselves and supporting their life, pick up groceries and do other things using that transportation benefit, which as we started to kind of empathize with that, we said, okay, well, maybe let's take a step back and not necessarily push the mail order option as firmly as we thought we wanted to in the beginning. And so just, again, being mindful and respectful of those existing relationships that our members have with their pharmacy team was critical for us, and understanding those drivers and those other benefits that come along with getting to use your local pharmacy. It made us look at all of those things a little bit differently. We also started thinking about things like, a common cause that people have to not get their medications is that they don't have refills. So thinking about, okay, well, you can remind somebody to pick up their med, but if they're out of refills, then they have to call their doctor and wait for another appointment. And that can take a long time. Every day that goes by, that clock is ticking on a medication adherence measure. More importantly, every day that goes by that they're not on their blood pressure medication, that's clinical risk that they're carrying. And so we started thinking about, what are the things that we could do partnering with our, virtual care provider groups and primary care provider groups to create bridge prescription processes to make sure that people have the medications that they need while they're waiting for that annual visit that they need for their provider. So we really started to look at closing gaps from the member's perspective rather than managing the measure from our own perspective. And we saw a lot of benefit, not only in our med adherence performance, but just in terms of member satisfaction and being able to relate to members on a different level.
Love that. I'm going to just repeat back what I think I heard and what I just wrote down as I'm taking diligent notes here. So at the end of the day, you need to look at the data. And what you guys noticed was weaker mail order uptake than expected. And so you dig into the data and you realize, some of your members, especially the duals, but probably not exclusive to the duals, they actually have a relationship within their community with their local pharmacy, whether it be the pharmacist or the tech or both of them. It could have been decades, right? And they want to go there. It's part of their interaction and experience. So the other thing you noticed was we have this great benefit around transportation for duals, and they use that for grocery shopping, and often a pharmacy is embedded in or right close by to a grocery store, so they rather use the transportation benefit to pick up their meds. So you need to look at that and obviously not push the 90-day as much as you were, the mail order as much as you were. So that was number one that I picked up on. The second thing I picked up on was common reason, obviously, for poor adherence is they run out of refills. And there's all kinds of headwinds, right, to connect with your doctor's office for refills. So what if we could partner with a virtual care provider? So it's like a couple of clicks on an app. You talk to a provider virtually. They're able to enable easier refill process.
You got it.
Goal.
Yep.
Beautiful. Incidentally, folks, I take better than average notes, typos included. If you want the notes of everything that's going to be discussed today, maybe you don't want to do the recording, you don't like reading transcripts too long, but you just want, Eric's notes. I offer those up to anyone that gives us 2 minutes of their time at 12:45 or on the East Coast, 45 minutes from now, wherever you are around, to just give us some feedback through our Survey Monkey. I'll email you. Everyone's going to get an email with our survey asking for feedback, what other topics we should cover, etc. And if you can take the 2 minutes to do that, all multiple choice, we'll send you my notes as a little bit of a carrot to do that. The feedback's that important to us, and I do take pretty good notes. So thank you in advance if you could do that. Also, we have a Q&A module here in Zoom. Of course, you know that. Help me co-moderate, ask follow-up questions or initial questions to our guests through the Q&A module, and I'll be able to incorporate them to the flow of today's conversation as best as I can. All right. I want to now move to the pharmacy teams and how they're driving Part D performance, and how, if we just focus on pharmacy, the pressure that the pharmacy team feels, maybe that's a little short-sighted. And maybe there's a different approach that really successful and effective health plans are taking. So I'm going to bring in Deanna Homer, COO at HealthTeam Advantage. Deanna, how are you guys approaching this challenge of ensuring better Part D performance by getting a more, the right teams involved?
I will say one thing is definitely we want to start at the very beginning and make sure our pharmacy teams are actually involved in the benefit design. So getting them working with our government programs team. We're also working to, really identify how do we get benefits set up that will actually drive our members, as Melissa said, to the appropriate place of service, whether it be our internal pharmacies or to our mail order vendors. The other thing, getting everybody involved. We make stars part of every employee's incentive. So we have corporate goals. Stars performance is one of our corporate goals. We always strive to be at that 4 or 4.5. And everybody's goals roll up to that. So we will literally talk to our member services and talk to them about how they can impact star performance. When they're on the phone with the members, they may identify, as Melissa said, does this member need transportation? Does this member need to use mail order? Are they having issues? And really just helping get everybody focused on Stars are my life. Stars are what we do. I mean, we are a 4.5 star plan, depending on which program you look at. And it's a lot of work on everybody's part. We really bring it out in all of our executive leadership meetings. It's something that we present to our board. So everybody is aware of our star performance and what our headwinds and our tailwinds are as it comes to star performance.
Okay, I think I might have missed some stuff at the beginning there, but this is what I grabbed. Please fill in the blanks for me. Pharmacy team needs to get involved at the very beginning with the government benefits team to actually set up the benefit design, right?
Yes.
That's number one. Then I don't know if I missed something. This is where I'm a little bit unsure myself, but you mentioned Part D measures are not just a pharmacy problem. And you actually align personal employee goals to one or more of the stars for every employee and tie it to their overall performance. And I guess by performance, I dare say their compensation in some regards. And you're asking them, how can you, Deanna, impact star performance? Maybe even like determine, for example, you gave member headwinds when you speak with members. Did I miss anything, or was that it?
That's it. We're really trying to,
Yeah.
we're trying to align everyone's goals. So it comes to our call center, it's our nurses and our case management team, it's across the board. Everybody is really impacting that star performance.
Right. Thanks for that. All right. And just, a quick shout out to all of our listeners and watchers right now. You're doing a subpar job helping me co-moderate. So bringing those questions. So far, we got Deanna and Melissa with great answers. If you have any follow-up or clarification questions that I haven't been able to unearth, please help me out and I'll ask those. All right, we're going to bring in Bita Farrokhroo. She's the founder and CEO of MedWatchers. Bita, for health plans, I know a lot of them rely on multiple partners to help with all different aspects, right, of the clinical programs like medication adherence. But from your experience working with different plans around the land, how have they integrated functions, and what advantages do you think there are in terms of outcomes, resource efficiency, overall member impact, if you're working with less companies, if you can consolidate or almost like integrate all of it into one?
Thank you for the question. I'll share a quick story that shows just how powerful and important an integrated approach can be and how a health plan's gap closure rate improved by 29%. One health plan we worked with had been outsourcing different parts of their medication adherence program, like some health plans do. One vendor handled eligibility and analytics, one made calls, and the other one handled text messaging. But here is the problem. When everything is spread out like that, it's hard to see what's really working and what's not. So they brought us in to help manage the entire process from start to finish, and the consolidation changed everything. Because of the full visibility that we had, we could track every step and learn in real life what works. So, for example, with the history of the patient that we had, we could see and predict what could be the answering rates for the patient. So if we made a call in the morning, next we made a call in the afternoon, or we could decide on the next step based on everything that we know about and we knew about the patient. Or if we have called in the mornings, then the next would be calling them in the afternoon. Or if we have called during the weekday, both morning and afternoon, then let's call them during the weekend. Or if we have called, let's do the text messaging. So based on everything that we have learned about the patient so far and our predictive modeling, then we would decide what the next step would be. And it's a constant learning, adjusting, improving, and moving forward. And we are now working on improving how we coordinate with pharmacies, which we expect will boost results by another 10%. Focusing on member targeting may continue to fine-tune algorithms, but the real opportunity to improve outcomes can lie elsewhere in the process. And it's not just about better data either. It's about attentiveness, about being nimble, pivoting fast, and tailoring outreach and focusing where it counts. That's what sets an integrated approach apart. You cut the handoffs, the guesswork, and the overhead as well. And in the end, what you get is more than just higher ROI. You get better care for members, smoother operations for the plan, and real measurable progress.
What were some of the impact results as far as gap and closure rates or anything like that? Do you have any like percentages you could share?
Yes, with the one health plan that we worked and we managed everything from A to Z, we were able to improve their adherence program by 29%.
Wow. Love that.
That's awesome.
Yes, and we noticed that with some tweaks that we made to our operations, we were able to get more consents from the patients, and more patients said yes to us getting red refills from the pharmacies.
So the consolidation, as you outlined, and I was scribbling quick typing. I'm not a good typer. I never learned how to formally type, so I'm pecking away. Consolidation allowed you putting it all under one roof. You're able to identify those process bottlenecks and optimize the workflows. And so that simple change in how like folks requested refill consent based upon the analytics and having everything under one roof allowed for all these great increases in clinical outcomes and adherence.
Right.
Great. I love that. Awesome. Folks, because we listen to your feedback, we're going to take that survey in about 25 minutes. We know that two of the biggest topics that you continuously want us to cover and bring in experts to discuss are both Medicare Advantage topics, of course, while you're here, and issues tied to like how are we appropriately applying new technology. We know what we're talking about here, AI, to help organizations do a better job taking care of patients. So we have two upcoming live shows. We call them live recordings. They're webinars just like this, all on Thursdays, 12 o'clock East Coast time if you're new to us. We have one on May 22nd on advancing specialty care in Medicare Advantage. And then we have one later in July on high performance health systems and how they're using AI to improve value-based care outcomes. If you want us to register you for those, so you don't have to go through the registration process, we're going to put up a poll right now, and we will take care of that for you. And if you can't attend, then you'll automatically get the recording sent to you. So too timely that you guys or your peers helped request through our Survey Monkey that we're putting together for all of you. Real quick, I want to take a quick segue into a question from one of our audience is stepping up with some questions. And just a reminder, everyone, it's just easier for me and Vakanda to manage Q&A through the Q&A module versus chat. So Philip says, in the standard of care, and I think this is, I'll start with you, Melissa, and then everyone could jump in. In the standard of care, the 80% threshold is commonly used to define adherence. But with the 90-day prescriptions, a patient can easily meet the threshold on paper while still being non-adherent in reality. How should clinicians and systems guard against this kind of the threshold, the trickery? He calls it the, quote, 80% threshold trickery when making decisions based on refill data, especially when it impacts care plans, quality scores, and reimbursement. So Melissa, I'll start with you, and then I'll go to Bita on it and end with Deanna. And none of you have to answer it if you don't have an answer. I just wanted to make sure everyone has a chance.
You bet. And thank you, Philip. I love this question. This is anyone who works in the Medicare Advantage space knows the math around medication adherence. And we also know what levers we can pull and what levers we cannot pull in order to drive that. So just to kind of walk everyone through the math here, if we're filling in 90-day supplies, we know that adherence is defined as 80% of the proportion of days covered, right? As was pointed out in the question. If you fill your medications in 90-day supplies and you fill 3 times in that calendar year, you'll have 270 of 365 days covered. That is not 80% of the days of the year. So in fact, on a true 90-day schedule, you've got to fill 4 times in a year in order to be classified as adherent. And so we do have to kind of drive that adherence, but that's not really the root of your question. I think the root of the question is, how are you driving adherence in terms of what the patient is taking every day at home throughout the year? And that's the better question. And the way that we do that is by counseling and education and asking probing questions. And I'll give you an example. One of the decisions that our plan made was to perform refill reminders and outreach for members who were who had just filled one time in the year. So for example, if we get a one claim for a med adherence drug, that person is not yet in our med adherence denominator, so it's not necessarily on the plan radar yet. But what we saw was that members would fill one time in, say, January or February. They wouldn't fill again until, for a 90-day supply, let's say. They wouldn't fill again until August or September. So they hit the denominator of that med adherence measure in August or September, and immediately they fail that measure. They're not adherent. There's no way for them to become adherent for the rest of the year. So I think the traditional plan view is, why should we do refill reminders for members who haven't yet hit the med adherence denominator? When we started, again, kind of thinking about what does that mean for us as a plan? What does that more importantly mean for our members? We made the decision to go the opposite direction and call everyone. If someone has filled a medication that's part of a med adherence plan, we're calling and checking in after those first fills. That's incredibly important, because if the member is skeptical about needing to use the medication, right? If they're not fully on board that they need a blood pressure med, for example, they may fill it once, but then they're still skeptical. They might not fill it again, or they may be experiencing side effects based on their first exposure to that medication that are scary to them, that are unpleasant to them, and that causes them to not fill it the next time. So those first fills are the most important opportunity that we in pharmacy have to find those issues, to figure out what side effects they're dealing with, to figure out what they're afraid of or they're skeptical about, and counsel them and educate them about the importance of adherence and work through whatever concerns or challenges they're experiencing, so that we can get them on our medication regimen that's going to be the most clinically impactful, the safest for them. And so based on that experience, our plan really does sort of focus on making sure that the member is adherent in a way that's the most meaningful for them. You're absolutely right. When we look at the numbers, there's a lot of math that goes into that. And we can't always control what the patient does every day in their homes. But what we can do is arm them with education and ask important questions of them about what their experience is like, so that we can address any issues that are arising.
Great stuff. I just want to summarize this real quick. At the end of the day, what I heard you say, make sure I got this right, Melissa, refill reminders, rather than just going after folks who only filled once a year or twice a year, because that's too late. Anytime someone gets a prescription, you call them all for a follow-up after that first refill.
We do.
First fill. Got it.
Yeah. Those first fills are important.
Yeah. Anything to add to that, Bita? Or are we good? Or same Deanna after you?
Yeah, we don't just help the patients and members order a refill. We have a longitudinal program that is pharmacist-led, and we learn about the patient and monitor the patients to make sure that what is the reason that they are staying behind. And there are many reasons. And what we try to stay on it, and we try to understand that we go beyond medications. We actively check in with members about their blood pressure, blood sugar levels, and work to identify and address any barriers that they might have and they might be facing following their treatments. And it's about treating the whole person and not just the prescription. So we call them just as is enough. Our pharmacist-led program is based on pharmacists calling and educating patients, making sure that they understand what is the medication that they are taking for, why they are taking it for, how often, and what dosing they should be taking it for. And then we don't let them go during the year. We follow up with them, and we just follow up with them the right amount of time. And so if the prescriptions are filled on time, we don't call them, but we keep monitoring them, and we make the calls when it's needed, and trying to understand, working like a concierge, understanding what is the real problem and how to solve it. Is it transportation? Is it that patient is out of refill? Is it that they can't get a hold of the doctor? Is it changing 30 days to 90 days, or understanding the reasons and acting on what the next right action should be?
That's actually a good transition to my next question, but I don't want to, Deanna, if you have something to add, I'll let you jump in on this one.
Yeah, just real quickly, one additional piece that we have, and in addition, Melissa's answer was very good. It's a lot of the same things that we do, is in our two largest hospitals here in Greensboro, we actually have a transitions of care program that's embedded within the hospital, and it's actually managed by pharmacists and a pharmacy team. So every member at discharge will receive consultation from the pharmacy team, and will have those first initial prescriptions actually filled before they actually leave the hospital. So before they are discharged out of the hospital, they are getting that first dose of medication so that we can actually make sure they are filling those prescriptions. If there are any issues with cost share or copays, that pharmacy actually has the ability to ensure that there's a patient assistance program involved, and getting them the lowest cost that they can, or getting it switched to a 90 or 100-day supply once they are back in the retail setting.
By the way, to everyone listening, I know I'm going to eat crow now because now there's so many questions coming in. I don't know if we're going to get to all of them in time. We're way off schedule now. Great job for making me look bad. I appreciate it. I want to stay on this topic around communication with the member, because digital literacy, I think, is still a significant hurdle for many MA members, especially duals, right? And so, Melissa, kind of to build upon your last answer, and Deanna's answer, and especially Bita's answer, what approaches are you taking at Banner Health for implementing a bridge to this kind of digital literacy gap, ensuring equitable access to all the different health resources and policy changes? And how are you kind of doing that at scale?
Yeah. Well, it's a moving target for sure, but it's one that we absolutely need to invest in. We know in our area, we have a provider shortage, right? It's difficult to find primary care, and it's even more difficult to find specialists in some of our more rural communities throughout Arizona. And I'm sure we're not unique as a state with that challenge. And so more and more care is offered and available in a digital virtual format than ever before. And we want to make sure that our population is ready to consume healthcare services and consume healthcare information in a digital format. And again, I think similarly to how we approach sort of pharmacy behaviors, we need to understand where our members are at. And the best way to do that is to ask them. And so for the last couple of years now, of course, this is driven somewhat by Medicare rules. We have started to survey our population to understand what their attitudes and behaviors are, what their confidence and competence levels are around consuming digital health information and consuming digital health surveys. And so, digital health services. So in our survey, we ask those questions, and we also have invested in a variety of different educational tactics. Some of them are mail outs. Some of them are training our own care management and customer care teams to help members download apps, for example, and troubleshoot issues that come up, so that at any touch point that our member has with our plan, there's someone ready to help answer those questions and walk people through, here's how you go and find this information, or so here's how you do that. But we also include things like how to use a QR code. I think for some of us who've been in the space for a while, QR codes seem like a natural thing to use these days, but we take it for granted that not everyone understands how to use that or what they're for, or how to find and differentiate legitimate health information online versus health information online that may not be as well vetted or as accurate as other sources and citations. And so, providing guidance to our members as to how to find that accurate information is really critical. And so those are some of the things that we've done, but we know that more and more of that information is going to be available only in a digital or virtual format. And so we've got to get our membership prepared. I'm really excited to share that, when we look at the distribution of, say, confidence levels of our population, when we first administered our survey, we saw this bimodal distribution. There are a lot of people that indexed as, I don't want it, I'm afraid of it, it stresses me out, I'm not interested in digital. And then on the other end of that spectrum, we had people that were very comfortable and confident in our population. And so we have to accommodate both of those perspectives, both of those preferences. But the second time we administered the survey, we started to see a shift. So we saw fewer people that were in that, not confident end of the spectrum, and more people that demonstrated confidence. But we're still very much needing to be able to manage both of those groups and both of those perspectives in our population. I'm predicting that we're going to continue to see a shift towards more confidence in the digital space as time goes on.
Great. I'm going to shift. I'm going to stay kind of on this engagement and talking about diverse populations. I'm going to bring back in Bita. Bita, for health plans who are trying to improve engagement, how have you seen, like, let's say, language preferences and culturally sensitive communications impacting outcomes, and how are health plans able to grapple with that? And if they are able to overcome those barriers, I'm assuming it's a strong impact, but that's not easy to do. So maybe take us through how health plans could address that.
That's a great question. Did you know that over 1 in 5 households in the US, they speak a language that is not English? That's a huge part of our population, over 21%, especially in healthcare where every patient matters, especially in STAR world. When I first started calling patients myself, I used interpreter services for the languages I didn't know, and they often led to poor member experiences. I remember this one call that lasted 45 minutes. It echoed for the patient twice between me and the interpreter and the patient, and he simply hung up. He got tired after 45 minutes and he hung up. So what we had in hand was the cost of translator, a claim that was not submittable. Health plan didn't get credit for the service that was provided, and patient was frustrated. A frustrated patient that wouldn't probably respond to our calls again. So that moment stuck with me. It was the turning point for us. I was my own barrier, so I decided to learn Spanish myself. Today, our team has over 180 full-time pharmacists, and 95% of us speak at least 2 languages, covering over 31 languages. We realized when you speak with someone in their own language, you earn their trust, calls go deeper, and they are often longer, and they are more likely to open up to you in a call that doesn't have 2 strangers. And it makes a big difference on how we start each call. We also built a technology that predicts a patient's language based on their name, and it's pretty accurate and it's simple, and it makes a big difference on how we start the call and conversation. And if the pharmacist doesn't speak the language, then we go to the next strategy, which is warm transfer. We did an internal study that showed that we were able to add additional 8% of, back then it was a CMR program, that we were able to complete additional 8% CMRs with only warm transfers. There was this huge story of an inbound call that came one day, and the pharmacist who answered the phone realized that English is not patient's strongest suit. So she asked if you prefer another language, and patient said Spanish. So the same pharmacist switched to Spanish. After a few seconds, pharmacist realized that Spanish still is not the strongest suit and asked, is there another language that you prefer? And he said Arabic. So on the same call, she was able to transfer on the spot the patient to the pharmacist who spoke Arabic. So in one call between 2 pharmacists and 3 languages, we were able to complete the call, and that was very rewarding. So the longs are deep, the calls can be deeper, and we meet the patient where they are.
Anyone who speaks English only but has the privilege of traveling, it's a bear if you're in a country that doesn't speak great English, right? My daughter was recently in the hospital in Madrid. She doesn't speak fluent Spanish yet, and she was there without us for a couple of days, and it was a bear. A lot of the nurses didn't speak great English, and it's such a better experience and produce better outcomes when you have that two-way communication. So I could totally see why that pays for itself in dividends. I appreciate you sharing that story. There's a really good question So I'm going to go a little bit off script here to our guests here and take a question from the audience around member incentives. You may be able to see it. I'm going to pause so you could think about it, and then I'm going to come to Deanna first, then Bita, and then if you have anything to add, Melissa, after those two answer, we'll come to you. Before we do that, I just want to give another shout out to our partner today, MedWatchers. They've never been more relevant in light of the 2025 CMS final rule. The bar has been raised for medication adherence, care coordination, and clinical oversight. You're hearing some of the cool things from Bita, but they have an advanced care management application platform, and it generates 2.7 million clinical interventions annually, combining strong clinical expertise that you just heard from all those pharmacists with innovative technology, and they're helping plans really drive an impact where it matters most. So CMS puts all this emphasis on documentation and the value of clinical services. MedWatchers is helping all of you scale stars-aligned strategies with pharmacist-led precision and measurable outcomes. It's really a perfect blend of bilingual pharmacists with technology. So if you're looking for a scalable CMS-aligned way to improve your Part D performance, you may want to check them out. Their adherence and streamlining operations, it's all checking the boxes for what they do. They're not a startup. They are a trusted clinical partner for over 300 different contracts, covering over 41 million lives, 200 dual eligible programs. So medwatchers.com. And in fact, I'm going to bring if you want, Bita's a great resource for a lot of, I've gotten to go back and forth with her. Free resource for information around Part D. If you want to just get a chance to talk to her, I'm happy to make a warm introduction through email, and I'll do that for anyone. We'll put up a poll while we answer this next question from the audience, and I'll make a warm introduction to Bita for all of you. I want to ask this question, and I'm going to start with you, Deanna. Can you discuss incentives for members to reduce the mistide to medication-related measures? Also, if there's a way to successfully rate, what is your rate to successfully connect members and get them to continue to refill through member services versus a vendor program, a partner program?
Well, I will say for Medicare Part D, it's really difficult to do member incentives since they have done away with the PDSS program. So you can't really do a member incentive around Part D measures. So that's very difficult. So you tend to have to look for other ways to incentivize members. So we try to do that through our benefit design by actually lowering the cost share on those medications that are in those adherence measures. So instead of having a $5 copay for their blood pressure medication, they may have a $0 copay for their blood pressure medicine, just to try and encourage them to actually use those medications. It's really hard to, retrospectively attribute member because you don't really know what's driving a member to actually fill that.
Well, I think you got it.
Okay.
You got everything. So,
Okay.
Oh, I guess if you're seeing better results from member services or partner programs that you have in place, I'll go ahead.
Yeah, I will say typically with our population, we do better with our internal call center than we do with vendors. Our big key is we're local, we're reliable. So when one of our healthcare concierges is actually calling the member, they're from North Carolina. They talk like the same way. They're easier to understand. Whereas some of our vendors are using, across not only different parts of the states, but also out into different countries. So then there becomes language barriers, as Bita was talking about. So it really makes our members uncomfortable and they don't want to continue those conversations. So we always try to push to see how much we can actually do with our internal staff.
Got it. Makes perfect sense. I actually that's a good segue. And I'm going to, guys, in the interest of time, jump right into operational efficiencies and then a little bit around some bright spots and positive deviances. I'm going to have to jump around a little bit here as we only have 16 minutes and a lot to cover. Bita, there's a few questions around AI right now in the Q&A module. And so I'm going to skip around and get to like, how are health plans leveraging AI to improve quality metrics, reduce costs? Where have you seen the greatest impact in supporting any plan priorities? And maybe if you have an example of a plan who's improving clinical effectiveness or operational efficiencies, it would be great to hear about it.
Yeah. Thank you for the question. As Jeff Bezos says, AI is not a product, it's helping the products that we already have and the processes. AI is changing the game in healthcare, and we've seen it make a real difference. Take quality assurance, for example, which is really important to us. Our pharmacists used to manually listen to the calls and take notes. It was a slow, time-consuming, and not the best use of their time. Now, with the use of AI, we are doing 95% of the reviews. We've increased the number of call audits by 50 times, and we are spotting issues 10 times faster. And we get back to the pharmacist right away, almost in real time. That means pharmacists can spend time reviewing and more time actually speaking with patients and caring for patients. And when the feedback comes instantly, we prevent mistakes from happening from when it happened until we catch it on the traditional QA. So we are also using AI predictive modeling in our programs, including hospital admissions and readmissions. What used to take weeks or months to model, we can now do in a few days, tailored to the exact population. We are helping. That lets us step in earlier, support the patient sooner, and reduce avoidable hospital visits. But here's the thing, AI doesn't replace the human connection. We believe the most meaningful care still happens through real connections, because sometimes it's something a patient says or the way they say it that reveals what's really going on. That's why we use AI to enhance human care, not to replace it. Technology helps us work smarter and focus where it matters most, but the heart of healthcare is the human connection that truly makes the difference.
Love it. Great. I'm going to jump around here, folks. I'm sorry. I want to get into like, let's just think out of the box and bright spots. It's my favorite topic, promoting sort of positive deviance. So I'm going to bring back in Melissa. Melissa, what is Banner Health, in your opinion, doing differently than most other organizations when it comes to, let's say, you just heard Deanna talk about the community in North Carolina. Like, what are you guys doing differently when it comes to the commitment to your community and your community members?
A great question. And I think it starts with understanding that we are a local health plan. We are proud of that. We are taking care of our neighbors and our family members and our friends. And so that is something that we very much wear on our badge. And in fact, our mission as an organization is making healthcare easier so life can be better. So where that translates for us is to understand and empathize with the journey that our members go through to receive healthcare services, and the challenges that they experience in the market that we're in. And so we very much focus on what those pain points are, and how can we make that experience as smooth as possible. There's so much that goes into delivering healthcare in a way that's seamless for the member. And I'll give you an example. So when, if we think about med adherence, which is the theme of the day, it seems the monitoring of the data. So if we see a claim reject in a pharmacy, for any reason, right? It could be the birth date was wrong, or the member ID number wasn't complete, or whatever it is. We see a rejected claim, calling that pharmacy and troubleshooting that claim before the member gets to the pharmacy to pick up their medication. That's work that we take on, right? We're calling the pharmacy directly. We're not calling the member, to get those things figured out so that when the member shows up, they get the med and it's a very smooth experience for them. They don't understand what happened behind the scenes to make all that happen. But we do all of those things. And it drives the best experience for our patient and member, the best experience for us. I think also we're compelled to understand the market that we're in and all of the delivery system assets that exist and some of the challenges that they face. We know that our primary care providers are stretched so incredibly thin. And so tactics to say, hey, let's ask our PCPs to do this, or let's ask our PCPs to do that. We know that's not going to land very well, given the challenges that they face. And so it requires us to not only understand what our members' journey is, but also what our provider ecosystem is dealing with, and take a shared ownership approach of all of that to make life easy. You know, we can't continue to add more and more to the primary care space without making their lives easier in other ways. And so we have to be very sober about that. And so that's a couple of ways I think where that shows up for us.
I want to stay with one more question for you, Melissa. Like, what about interacting and leveraging members to improve your processes? And, you know, CAPS is so important, of course. So, like, what are you doing from the bottom up, right? A big thing about bright spots and positive deviance is the solution's got to be usually bottom up, not from the top down. What are you guys doing in that vein?
Gosh, it's a great question. One of the ways that we do that is through our enrollee advisory councils, which are groupings of members from all walks of life who come together and provide us with feedback and insights and advice on what their experience is like, on things that we may be thinking about that react to, you know, newsletter materials, or if we're thinking about going in this direction or that direction, they can kind of weigh in on it. So they're incredibly insightful. And I would encourage anyone who is making a large kind of, you know, benefit design decision or directional decision to incorporate the perspective of the member. You know, we all have our own biases and blind spots. And I know, for example, I live in Phoenix, which is a very urban place. And if I go down the street, you know, a mile down the road, I'm probably going to pass by 2 or 3 pharmacies and probably a couple of clinics, if I'm being honest. Healthcare is all around me where I live. And so I can't necessarily anticipate what it's like for someone who has to drive 30 miles to get to the nearest you know, building, let alone healthcare service. And so making sure that we're hearing from people who have different experiences from ourselves is critical in the process. And those enrollee advisory councils are so incredibly enlightening for us to help us make the best decisions possible.
Great stuff. All right, rapid fire here. We got 9 minutes. I think we could cover a lot here. I want to cover Medicaid briefly, and then I want to see if we get back to CAPS and talk a little bit about what Deanna is doing to close things out. Bita, I'm going to bring you in to talk Medicaid real quick because it's a significant topic right now, and we're talking about duals here as well. So how do you see opportunities for people listening to help with their Medicaid products and reduce cost of care?
Great question. One health plan that we worked with realized something really important, that the traditional Medicare programs just were not enough, especially with their Medicaid population. Like many others, they started out using traditional medication therapy management or using the PDC scores to tackle adherence issues. But despite all of that effort, they weren't seeing the impact or the ROI that they were hoping for. So we sat down with them to take a new direction, and we took a new direction. Instead of casting a wide net, we focused in and we started looking at the real drives of the cost, things like hospitalizations, readmissions, and mental health. That's when we introduced a more tailored solution, comprehensive medication management, designed specifically for high-risk, high-cost Medicaid population. And here is what makes the difference. It's not about what program you run. It's about who you reach, when you reach them. The timing is really important, and how often you follow up. Too often, past programs failed because they weren't targeted, they weren't timed right, or they didn't go deep enough. So we changed that by using smart analytics to find the right members, deliver the right interventions at the right time, and build relationships that last. Because in Medicaid, it's not just about a single call, it's about ongoing, meaningful contact that helps member truly change behavior, which is where the real transformation happens, and it works. With our customized models, we typically see a 4-to-1 to 12-to-1 ROI, and we are confident enough to guarantee it in many cases. But even more than saving, it's outcomes that matters. Better plan programs, better care.
I like that a lot. You know, question, and I'm not saying you guys necessarily are doing this, and I know you're not sitting there writing code, but you're a pharmacist by training. But how do you think AI and machine learning algorithms, do you think they can be designed to analyze chart data patterns and create real-time sort of med management interventions that are going to be allowed to reduce a lot of the headwinds that we've been talking about. I don't know if you could comment on that or kind of forecast a bit for all of us.
I think AI will help. We use a lot of AI to understand where the patient came from and what our next step should be. So definitely it helps in automation and predicting. But again, at the end, it's the human connection that matters. And changing the behavior of the patient is really what makes the difference. And that needs and requires human connection at the end.
Got it. Great. I like that. I'm going to bring back in Deanna Homer at HealthTeam Advantage. Deanna, I mean, the healthcare system's taxed, primary care ridiculously taxed. And because of that, obviously this creates challenges for all plans, but especially MA plans, to maintain a strong member experience, a strong caps. We talked about the medication adherence. We heard a little bit of a virtual care way to kind of usurp that headwind. How are you guys thinking about these challenges and using it as an opportunity to improve value for both the member and maybe the provider on the other side?
I'm going to say we did, really recognize that our PCPs are really strapped. Approximately 80% of our members are actually going to our system physician groups. So many of our largest practices there actually have an embedded pharmacist. That embedded pharmacist also has a team of supporting technicians that are working behind the scenes with them. So that team of pharmacists and pharmacy technicians are actually taking over some of the former roles that the PCP staff would have to take, either the physician or the nurse.
When you say embedded, physically in, or are they kind of a virtual kind of curbsider?
Our pharmacists are actually in the office, so they will be in the office. They are actually seeing members when they are actually in the clinic. They can make appointments. They will also do things telephonically. The technicians themselves are not located within the practices, so they are working in the back end in an office setting. So they are actually the ones that are submitting the prior authorization requests for the pharmacist. So when the technicians are actually putting in a prescription, they can run a test claim if there's a new prescription that's written. As soon as they identify that that claim requires prior authorization, those technicians are able to pull the information that's needed, go into Cover My Meds or whatever online system a practice uses to actually submit the authorization for the PCP on their behalf. So it's getting the prior authorization actually resolved before the member gets to the pharmacy to pick up the prescription. It also, the pharmacists are able to do dose titration and actually change any medications as they're doing their medication reviews. So it really helps the members have an additional person other than their doctor or going to the local pharmacy to actually be able to address any medication issues.
That is good stuff. 3 minutes left. I'm going to put Melissa on the spot, but you could ask for a lifeline for your fellow two panelists. This is a question I wanted to get to before we ended from Jason. How can Part D chart data be enhanced with pharmacogenetic information to create sort of more of a personalized or precision adherence strategy for each of the individual genetic profiles that a plan may be working with?
Oof, that's a big question. That's probably its own hour. I would say that, if I were to editorialize that a little bit, I think pharmacogenomics is still very much a budding clinical space. There has been so much learning about the role of pharmacogenomics and medication outcomes. That being said, the adoption of pharmacogenomic data into electronic health records, where the clinical informatics component gets added in to say if this person has this sort of genetic profile, then and I go to write for, maybe I'm a physician and I go to write for a prescription medication that is not the best given that person's genetic makeup. there's a flag that says, hey, what about this other alternative based on this rationale? That's I think where there's still so much opportunity for development and growth, is taking the data, getting it ingested in a meaningful way into our electronic health records, and then writing clinical rules against that data, so that at the point of prescribing, the information is presented in a clinician in actionable format. That's an easy thing to say in like a sentence or two, and the delivery of that, like the execution of that's so much more work, right? So I know I just have a couple of minutes, but that's kind of my initial thought, is that we've got more work to do in that space.
To that end, folks, take that survey, you get my notes, but then maybe we do an episode completely on this, right? So Jason, your vote only counts if you go take the survey. No, it's a great topic. And yeah, I'd love to dive in more on that. It's a really cool topic. Listen, I want to thank everyone who's listening for tuning in today. It's an hour. We don't take the time you spend with us for granted. I don't care if you're watching live on Zoom, you're taking a walk, listening to us on a weekend, you're at the airport right now listening to the show. We hope you use the bright spot shared today to inspire your thinking, enhance your company's current approach to improving healthcare for all of us. A special thank you to our three incredible guests. You guys were awesome, and I appreciate all the time you took to meet with me ahead of time to prepare for this. Really do. We produce this show for all of you. So I always like reminding folks, this is your Bright Spots in Healthcare podcast. Take care, everyone.